is Dr. Alan Bowling. I'm the director of the Neuro Health Institute in Englewood, Colorado. I'm also a clinical professor of neurology at the University of Colorado. I'd like to welcome you to this program on cannabis and MS, benefits, risks, drug interactions, and research update. I have some formalities to go through before we start the program. So in support of improving patient care, the CMSC is accredited by the Accreditation Council for Continuing Medical Education, the Accredited Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. This presentation offers one contact hour of continuing education for physicians, nurses, pharmacists, PAs, psychologists, and social workers. So these are my disclosures. And these are the learning objectives related to therapeutic effects, side effects, and special considerations related to dispensary cannabis products. So this is the summary of the talk. I'm going to give background information that's going to be kind of curated for a clinician's perspective on this topic. And then I'm going to get into quite a bit of detail about efficacy of cannabis in MS, but other medical conditions, talk about safety quite broadly, talk about drug interactions, talk about specific concerns related to cannabis dispensary products. And then I'm going to end with trying to pull all that information together into an approach that MS clinicians can use on a day-to-day basis. So I want to start in terms of the background with kind of why I'm doing this talk, why I'm doing education in this area. I think that there is, and there's evidence to support this, what's been described recently as a clinical void, where we have clinicians on one side and people with MS, other medical conditions on the other side, and there's kind of a void that does not usually exist with therapies that people with MS and other medical conditions that are using. So on the clinician side, there's a lack of knowledge. There also are barriers towards obtaining the knowledge, such as being familiar or not familiar with herbal medicine, not fully understanding state versus federal laws and regulations. There's also a topic, I'm giving a 1-hour talk, but I don't think there's anyone who can take in the necessary information in 1 hour. So I think that's a barrier. And I think often people's own gut emotional response, their political views, positive, negative, can be a deterrent towards really obtaining objective information to then share with people with MS who are interested in potentially using or who are using cannabis. And this is an important issue because kind of on the other side of the slide there, you can see that this is commonly used. Cannabis in the general population in the US, it's about 8% with more men than women. And then people with MS, it's generally about 20%. That's kind of the average of studies, but you can see there's a range as to the number of current users. And then you can see there's a recent study showing that only 20% of people with MS who are using actually discuss with their clinician. So this raises concern that we have kind of an epidemic of poorly informed decision-making in this area, cannabis use in people with MS. So this has been studied, the fund of knowledge among healthcare providers. There's lots of information out there, more than 30,000 articles, more than 200 articles coming out per month on cannabis generally. And then in terms of US healthcare providers, most states do not require physicians to have training. There's a study showing residents and fellows, only 90% of them are not at all prepared to recommend cannabis. Only 35% are prepared to answer questions. Study in my state, in Colorado, of various health professionals found that only 1% to 2% were completely trained about the health risks. Similar in Canada, physicians and nurse practitioners report a large gap between their current and desired knowledge. I think another area that just has not been studied, and I want to touch on briefly in my talk, is that cannabis is a form of herbal medicine. And I think most conventional clinicians have little or no training in herbal medicine. So I think it's hard to take cannabis information and put it into kind of a bucket of knowledge that you already have or a foundation of principles that you have. A little like trying to learn about a new drug, conventional drug, and you never took a pharmacology class. So there's a recent study looking at physicians' knowledge. So the CCKAS, looking at knowledge assessment survey in American physicians. So more than 500, similar to numbers I showed earlier, 21% had no cannabis training. And it really was a quiz of their knowledge base. And it went from the botany, you can see the cannabis plant, environment, climate. 54% answered the questions incorrectly in terms of THC and the two cannabinoid receptors. 47% answered incorrectly. In this quiz, they were, it was a little harsh, some parts of the quiz. They asked about nanocannabinoids. Those don't even exist. They just made up that word. 33% said they were familiar with those. 9% said CBD had no side effects, and 12% CBD produces euphoria. The part of this that concerns me the most is the bottom statement there. So that for dispensary products, 17% of physicians thought those were FDA controlled, 25% thought that they were FDA approved. If you look at pharmacists, similar study recently done in California, 5 to 12% high level of, or professional level of knowledge about various aspects of cannabis. And then there's been so many of these studies about fund of knowledge among healthcare providers. There's recently been a systematic review of 26 studies. And the conclusion of this report, which actually fits with my impression in my state and other states that I traveled to in the US, the conclusion was the clinicians, the healthcare providers were relatively supportive of cannabis in clinical practice, yet this is counterbalanced by a lack of confidence, a lack of self-reported competence, and concerns for the associated risks. So that gets back to where I was talking about the fund of knowledge and then the barriers to that knowledge and potential emotional, political swaying of people's views without having a full knowledge base. Other places to get maybe users on their own have a knowledge base. That's been looked at really just more recently. We haven't had lots of studies in this area, but the study by Kruger, just published a few months ago, found that people's who were using cannabis, their main source of information was their own experience, then friends and family, then dispensary staff, and lowest on the list was actually a primary care provider. Same thing, they gave these people a quiz. 76% thought cannabis was effective for cancer. 82% did not know it could cause psychosis. They did not know, 78% did not know about the lower birth weight data. 70% did not know it increased motor vehicle accident risk. And interestingly, more frequent use was inversely correlated with knowledge. And then another study published in the Annals of Internal Medicine showed that, and this is a very large study, 9,000 cannabis users. Of those who used in the past year, 53% did not think it was addictive. And when you looked at all people who were questioned in this survey, 37% thought it had preventive health benefits. When edibles were taken, 29% thought smoking or vaping cannabis had preventive health benefits. And there's not good evidence that cannabis is effective for anxiety or depression, but 47.9% thought that it was. So we're back to this. We have this void, especially clinicians not having knowledge, maybe having barriers to obtain knowledge, and then a large number of people in the general population and even a higher percent in our patient population who are currently using. So my goal in my talk today is to try to fill in this void. So in terms of background information, cannabis is not new to humans. It's been around for thousands of years, goes back to ancient China, ancient Sumeria. It was present in ancient Greece. In terms of the US, the 1970s to the present has been kind of a shift in the swinging of the pendulum from to decriminalization at the state level, and then medical cannabis laws actually now passed in 47 states, plus the District of Columbia, and then recreational laws in 11 states, District of Columbia, and some US territories. And then I think this is a critical element that it appears that many healthcare professionals in the US are not aware of, that there's a federal ban in the US on marijuana, and that's resulted in a patchwork of regulatory strategies that are not uniformly consistent with the approach usually taken by the federal government and whose effectiveness remains unknown. So the way the cannabis programs are happening in states is determined by each state, and each of the states have unique features to their programs. So we'll get into that in more detail. But this just kind of highlights the FDA process that I think many of us are familiar with, where you do basic science studies, preclinical studies, human trials. If those are positive with phase 3 studies, then you go to the FDA, have the FDA do an independent risk-benefit analysis. If it's approved, there are good laboratory and manufacturing practices, standardization. There's a prescribing information, the patient package insert that has to be approved by the FDA. And then those products go to a pharmacy where they're dispensed and monitored by trained, licensed pharmacists. And then you can see medical marijuana really doesn't consistently meet any of those criteria. I think a crux of what happens in this world is the bottom two points of this, that there's lower cost, easier access with the dispensary medical marijuana products as opposed to FDA products. But I think those multiple elements above that really need to be kept in mind, and we'll discuss that as we go through the program. So in terms of just some very basic botany, this is the cannabis plant, the female on the left, male on the right. This is cannabis sativa, there's indica. It's a very promiscuous plant. There's all kinds of hybridizing that's been done. So there are now thousands of subspecies. In the end, they're all thought to be subspecies of a single species of the cannabis plant. Two main categories that I think a lot of people are not familiar with, especially in the US, are marijuana and hemp. The broad term we tend to use in the US is marijuana, but that's really used incorrectly. The broad umbrella term is actually cannabis. And then marijuana has higher THC, hemp has lower THC, but higher CBD. And then this sort of describes in further detail the differentiation between cannabis, marijuana, and industrial hemp. Often in the US, people talk about medical marijuana that has high CBD content and low THC. That really makes no sense. That's medical cannabis or hemp. Anything in the marijuana category is relatively high with THC. Getting into definitions further, cannabinoids, those are all cannabinoid receptor ligands and related compounds that can be naturally derived or synthesized. Phytocannabinoids are those cannabinoids that come from the cannabis plant. Endogenous cannabinoids that we'll get into, or endocannabinoids, those are cannabinoid molecules we make in our bodies. And then synthetic cannabinoids, these are very high affinity agonists that have very serious side effects. We're not going to get into those, but terms that are often used for those are spice and K2. As I mentioned at the beginning, I think a lot of conventional clinicians may have a hard time learning material in the area of cannabis because it's an herb and it doesn't fit into the single molecule preparation that we're used to, that's created often by synthetic chemistry methods. So we're starting herbal medicine, you start with a raw plant. So these plants contain a lot of different compounds. They have their own microbiome, and these different compounds, microbiome, may be unknown. They may be unidentified, poorly characterized. There may be toxicity. There may be drug interactions. And we're dealing with often hundreds or thousands of different molecules in an herbal preparation. Quality and composition can vary depending on the plant. When it's harvested, what type of exact plant is used. Also basic principles of herbal medicine. They just generally be used for a short time for benign self-limited conditions. Should generally be avoided in women who are pregnant or breastfeeding. should avoid or use caution in people who have multiple medical problems. And this is something where there should be ongoing discussion with a clinician who's familiar with the herbal products that are being used. So now going back to cannabis, this is how in my state this happens. So these are all photos from Colorado. You can see the field of cannabis plants. It's kind of in the middle there on the upper left. And then you can see the harvest time. And then if you look closely, you can see the plant is being divided up on the left for recreational use and on the right for medical use. And then you can see the bud of the plant that's often sold in that form, but also many others. And then ultimately these products end up in dispensaries. And these are the types of products. You can have more of the raw product on the top, leaves, buds, stems combined. Then you can have the buds or inflorescence, and then you can have particular extracts where the THC content starts going up because you're selectively pulling out more of the THC and other cannabinoids. There's a resin on the plant. If you just remove that resin, that's what hash is. That's the bottom left. And then you can do various extracts of hash or other forms of cannabis to get very high THC concentrations, up 50% or more in the most concentrated preparations. And this sort of summarizes that in these cannabis-based products. So the plants have 5 to 20% THC, the resin or hash 5 to 20%, and then cannabis oil, the various extracts can go up to 75% THC. And lots of ways to take this in: smoking, inhaling. There are oral forms, can actually put it on the skin. Oral mucosa, rectal mucosa has been used as well for suppository use. And then there's a different class of cannabis products that are actually medications that go more, or they do go the FDA route. So pure THC, that's known as dronabinol. It's available as Marinol or Syndrose, and this has actually been FDA approved for chemotherapy-associated nausea and vomiting, also AIDS-associated weight loss. And the Syndrose is a liquid formulation of the Marinol. There's a synthetic variant that's very similar, but not identical to THC, called Nabilone or Sesamet. Its indications are similar. And then there's a newer product approved about 2 years ago, cannabidiol, which is essentially nearly all cannabidiol or CBD. So it's more than 98% CBD. And that's been approved for pediatric epilepsy. We'll get into details of that in a few minutes. And then there's a different product, not approved in the US, but in multiple other countries, Sativex or nabiximols. This is an ethanol cannabis extract. It's an oral mucosal spray. And it's roughly 1-to-1 ratio of THC to CBD. And it's approved in other countries, like I say, for MS pain and spasticity, and also for cancer pain. And this is how, for example, Epidiolex is prepared. So you have a very secret greenhouse in the United Kingdom. No one knows exactly where this is, that has cannabis plants that they've hybridized in a very methodical way. And they started this whole procedure more than 20 years ago. And then they do preparations from the plant. And then they do very specific extraction methods, CO2 extraction, other processes you can see on the right there, and then end up with a product that's not 100% pure, but it's more than 98% CBD, and then that goes into pharmacies and dispensed by pharmacists and prescribed by physicians. So you can see there are differences. The photos kind of highlight this is how state products are developed versus the pharmaceutical grade products. So going back to the definitions and more into the pharmacology. So cannabinoids, now we'll kind of dive deeper into what cannabinoids are. There are many different active molecules. The one most people are familiar with is THC. That's on the top right there. You can see the space filling model in purple. Cannabidiol is below that. It has very different pharmacological effects, but you can see it looks very, very similar to THC. And there are about 100 other cannabinoids. And this is a very complex area pharmacologically. So if you look at potential actions of these molecules. They're the CB1 receptors that are present on neurons. They're preferentially concentrated more in particular brain regions. So the basal ganglia, cerebellum, hippocampus, much more than the brain stem. And there is a process that the CB1 receptors, they kind of decrease excessive neuronal activity. We'll get into, that's referred to as DSI, DSE. So that's depolarization induced suppression of inhibition or excitation. And basically that means that there's excessive inhibitory or excitatory input, and CB1 receptors decrease that excessive activity. And CB1 is actually the most abundant G-coupled receptor in the central nervous system, so it's quite widely, it's very concentrated in the CNS. It's been evolutionarily conserved, and it's actually so widespread that there is concern about how druggable it is. If you have a drug target that's too broad-based, you may end up with less selectivity with side effects and more concern, or less selectivity with efficacy and more side effects to address. There also are CB2 receptors. These are present on lymphocytes. And then cannabinoids have many other potential effects. You can see some of them listed there, like antioxidant, cytotoxic, calcium flux effects, and these, many of these effects are independent of CB1 and CB2 receptors. So now we get into the further complexity. The next several slides I'm not presenting to have people take in all the minutia, but just to kind of highlight the complexity of the pharmacology in this area. So you can see the top left there, the THC type cannabinoids. There actually are 18 different types. Those make up 17% of the total phytocannabinoids. A lot of people haven't heard of CBG, that's cannabigerol. That's actually 16%, so that's the second most predominant cannabinoid. And the 17 different CBG subtypes. CBN, cannabinol, you can see there, that's third on the list. CBD, which is what people have often heard of if they've heard of anything beyond THC, and that's actually the fifth most common cannabinoid, and actually are 8 subtypes of CBD. If you kind of go down the list, near the bottom there, the total cannabinoids, so it's more than 104, and then there are more than 400 non-cannabinoid compounds. So THC, this is the main psychoactive constituent. It primarily affects CB1, CB2. It's a high affinity agonist at these receptors, but it does have many other pharmacological effects that you can see on 5-HT, TRPV1, TRPV2. This is where capsaicin acts, also affects calcium, potassium, sodium channels, and importantly, THC may well have pro-convulsant effects. And then if you look at CBD, it has multiple effects that are actually the opposite of THC, including it appears it does have the anti-convulsant effects, and it is not psychoactive, and it has very low affinity for CB1 and CB2 receptors. And then I show this slide just to show you there are many pharmacological mechanisms of action potentially for CBD. And like I said, most of these effects are not, these are not CB1, CB2 receptor effects. So I think this quotation really summarizes this area. This is from a pharmacology journal. Even slight structural differences between the phytocannabinoids can produce very diverse and competing physiological effects. So you can see if you have 104 cannabinoids and they have very different and sometimes opposite pharmacological effects, it can be essentially impossible to know how a particular preparation is going to affect a human unless you have a standardized product and you do standardized testing for efficacy and safety. So that's what I mean by this slide. I think a lot of people think, you know, if cannabis works in one situation, then any cannabis product must work in other situations, but these are very different preparations, and you really have to know what's in the cannabis product. And then there's a whole different group of cannabinoids known as endogenous cannabinoids or endocannabinoids. These are very similar to endorphins, kind of pharmacologically active molecules that we make in our own body. The two main types are anandamide or AEA and 2-arachidyl-glycerol or 2-AG. There are multiple other endocannabinoids that have been found. And the pharmacology is quite fascinating here. I showed you the THC stick figure and then the space filling model earlier. And then if you look at the space filling model for anandamide or AEA, it's very similar to THC. All these cannabinoids are very lipophilic, which means the endogenous ones can't be stored in vesicles like neurotransmitters because they would just diffuse through the membrane of the vesicles. So these can only be made on demand. And their primary function, like I said, is to tone down excessive neuronal activity, sometimes referred to as a synaptic circuit breaker effect. And there are other functions of endocannabinoids that are actually a very active area of current research. And this just shows the synaptic cleft, and my point in showing this is that you can see the axon terminals and dendrites, and typically neurotransmitters go from the top to the bottom, and the unique aspect of endocannabinoids is they go the opposite direction. So if there's excessive postsynaptic neuronal activity, then the endocannabinoids are sent backwards to the inputting neurons to decrease the activity of those neurons, and that's whether they're excitatory or inhibitory neurons. So now I'm going to go through efficacy studies in MS and then other medical conditions. Very importantly, and like I said, I think this was missed by many physicians in that study I mentioned earlier. The bottom line point there is there are no formal clinical studies of the efficacy of any products sold in US cannabis dispensaries. So most of the studies I'm going to show are with standardized preparations with pharmaceutical grade products. So lots of references here for the general effects. There was a National Academy of Sciences Engineering Medicine publication published in 2017. I'd highly recommend that, and I will give a quick way to kind of read the summary of that. Neurologic disease, MS, there were sort of sister publications several years ago. I was an author on the MS publication, co-author with multiple others, and then lots of literature in the epilepsy world. In MS, this was the first study. It was actually reported at the AAN in 1979 by Petro and Ellenberger. They had 9 patients with MS who had spasticity. They had their own self-developed spasticity measure, and you can see 5 or 10 milligram of THC producing an improvement in this objective measure. It's interesting, this data is quite different than the current data where we don't see objective changes, for example, in the Ashworth score, but people have subjective improvement. In their initial studies, it seemed like it was more objective than subjective. Subsequently, there have been many clinical trials, certainly 17 higher quality clinical trials, more than 3,000 people with MS studied, and significant findings for subjective spasticity, pain, bladder dysfunction. Interestingly, the most significant treatment effect was with products in industry-funded studies, may relate to the products that were used, but also the enrichment strategies were used in those studies. Also, they looked at the standardized mean difference, a way to kind of standardize between studies. And the SMD, standardized mean difference, was 0.09 to 0.25, which is actually relatively low. Standardized mean difference for Leorisol and some bladder medications is 0.58 to 2.41. So a conclusion of this systematic review, meta-analysis, was the results suggest that there's limited efficacy for these symptoms. Importantly, if you look at the formulations, these are standardized formulations. There really only is one study that had smoked products. So that's important distinction to keep in mind, that where we see the therapeutic effect, that's been with standardized preparations that are not available in US dispensaries. If you look at all outcomes for all therapies, you can kind of see the positive and negative data. The bigger the symbol, the higher the quality of the study. And I think it's interesting when you include all outcomes, you look at sleep, it ends up fairly high on the list. It's usually a secondary outcome measure in these MS studies, but interesting to see it come back pretty consistently, and actually more consistently than bladder. But like I mentioned, that's a secondary outcome measure. If you look at real world use in Denmark, the largest study to date, an anonymous questionnaire, what they found kind of fits with what I just showed you, that people with MS were mainly using for pain, spasticity, and sleep. Recent British Columbia study using electronic medical record and survey also found pain and sleep were highest on the list, then mood, and then spasticity. And all this fits with my clinical impression. Colorado, we've had medical marijuana legalized for nearly 20 years. And over that time, where I've seen it benefit people most is with MS-associated pain or spasticity that often interferes with sleep, and a little bit of cannabis seems to help people with these breakthrough symptoms, which can happen in the afternoon, but especially evening and night. And very anecdotally, people report with MS more benefit with preparations that have more CBD than THC, but we do not have studies to document that. Now we're going to go through other efficacy for cannabis. I'm going to go pretty quickly through here, but recent studies indicating using Ashworth score improvement in ALS-associated spasticity, epilepsy studies approved in Dravet and Lennox-Gastaut, and then tuberous sclerosis complex recent study showing benefit there as well. There are no studies in adults with cannabis with epilepsy, and very importantly, THC may have proconvulsant effects, as I mentioned. There's evidence for pain generally, including peripheral neuropathy, pain, conclusive or substantial by the National Academy of Sciences, Engineering, and Medicine report, and that's sort of the shorthand version I have there. You'll see that on many of my slides. But this has not been entirely consistent. For example, nabiximols was not effective in two randomized controlled trials for cancer pain. There was some benefit seen in subgroups there. Sleep disturbance, especially the second point, that it may improve sleep quality and decrease nighttime disturbances in conditions that interrupt sleep. And that's an example that would be people with MS with pain and or spasticity that interferes with sleep. And then other conditions, Tourette, limited data. The best data we have for any condition is chemotherapy-induced nausea and vomiting, HIV and AIDS. They show improvement in increasing appetite and decreasing weight loss, limited evidence there. And then no or insufficient evidence from multiple cancers, cancer-associated cachexia, irritable bowel syndrome, other types of spasticity, addictive substance use, schizophrenia, and then there's actually limited evidence for it not being effective for multiple conditions you can see, dementia, depression, and then interestingly also in glaucoma, and we'll come back to that in a few minutes. So it's interesting, if you look at the approved conditions, I've just kind of taken a summary approach here. So these are the conditions approved in states across the US. Most states don't have all these, but they have some subgroup, often about 2/3 of these. And then if you look at these approved conditions and then color code it, it's quite interesting. Green means we actually have evidence to support use. Yellow, it's unclear. Red may actually be negative effects. And you can see it's a complex picture. There's lots of granularity to this that I think is lost if there's just a listing of these 8 conditions are approved for cannabis. So as an example, seizure disorders, that's green and red because for CBD, there is good data at this point. But for THC, it appears to be the opposite. It has proconvulsant effect. Similarly for cancer, like I said, the best data we have, which makes it green to some extent, is chemotherapy-induced nausea and vomiting. For most forms of cancer, though, it does not have any beneficial effect on the underlying cancer. And I'll get to it in a few minutes, but some types of cancer, like testicular cancer, nasopharyngeal cancer, it may actually have negative effects. So now in terms of safety, this is an interesting aspect of cannabis that has been around for hundreds of millions of years, but it's still poorly understood in terms of the safety, and that's because it's been used in more casual, not monitored settings. So where we have data for safety is mainly observational studies, kind of listed there, larger databases, ER visits, hospitalizations. There are lots of confounders. So I think when you look at safety, you have to be careful to not cherry pick like one case report of something and maybe it was just coincidental. So when I go through the safety, I'm going to rely on these larger databases, hospitalization data, ER data. You'll see, and much of the data I'm going to show is actually presented by the National Academy of Sciences in that publication I mentioned. And importantly, and like I say, I think I showed you that survey earlier of physicians in the US. I think many do not know the bottom line point here, that no products sold in US dispensaries have undergone detailed preclinical or human safety evaluation. So in terms of cannabis, it's generally well tolerated in neurological trials. When there are side effects in neurological clinical trials, you can see kind of the side effects in descending order. So dizziness, dry mouth, nausea, fatigue, somnolence, kind of go down the list there. In terms of MS studies, these are the most common side effects, pretty similar: dizziness, vertigo, dry mouth, feeling drunk, impaired balance. And then importantly, CBD, which has gotten very popular, very widely available. There actually are very limited human studies about its safety, especially for chronic use. Genotoxic and hormonal studies are scarce. And then other side effects of potential neurological relevance for cannabis products generally are visual difficulties, seizures, especially if THC is used, and just sort of generalized weakness has been described in adults under age 25 that can be impaired brain development, probably related to synaptic pruning, axonal migration abnormalities. And then something that's been relatively unstudied, but might be in the 5 to 10% range in some studies, is fall risk. And then there are actually more than 100 case reports, and these have been put together in some more recent series, but more than 100 case reports of stroke. I think this is an important area for MS clinicians to be aware of because the stroke syndrome that's been associated with cannabis is RCVS, so reversible cerebral vasoconstriction syndrome. And this may mimic an MS attack. And for RCVS, you do not want to treat that with steroids because that can actually worsen the condition. So that's sort of a bottom line to the next few slides I'm going to show. So RCVS, there's a lot of literature on this, but it may not be well known to MS clinicians. People are more aware of this in the stroke world, but typically presents, but not always, with a thunderclap headache. And then there's this segmental cerebral vasoconstriction. And then the multiple triggers, including cannabis, sex can be a trigger, sexual activity can be a trigger, and it can be associated with subarachnoid hemorrhage. And it lasts a while, can go out 12 weeks. And like I say, the treatment is not with steroids, but with calcium channel blockers. And the current concern is that steroids, not that steroids have a neutral effect in this condition, they can actually increase the risk of stroke and death. So multiple studies that indicate that state steroids should be avoided. I have a couple of quotations from papers. Most importantly, clinicians should refrain from prescribing glucocorticoids in patients with suspected or proven RCVS. Another report of 4 fatal cases. All of those RCVS patients have been treated with steroids. So the concern here is that RCVS, with its stroke symptoms, can mimic an MS attack, and steroids could be a dangerous thing to prescribe in these patients. If there's concern about RCVS, the way to rule it in or rule it out is with CT angiography. And then other side effects of neurological relevance are cognitive dysfunction, especially in the general population with memory, attention, and learning, also decreased reaction time. A really interesting study, well-done study by Anthony Feinstein that was published last year. 40 people with MS smoked cannabis at least 4 days per week for multiple years. They did have cognitive impairment in at least 2 domains. Half the group came off of cannabis, the other continued, so sort of 50-50 allocation. cognitive screening of multiple outcomes. What they found was that there was improvement in all measures at a very statistically significant level for verbal and visual memory, processing speed, and executive function. Certainly makes you think if we have someone with MS who has cognitive difficulties and they're a regular cannabis user, a very obvious intervention would be to try to have them discontinue cannabis use. Other side effects to be concerned about are addiction. I think this is very underdiagnosed. The DSM-5 defines it as cannabis use disorder. Overall, in cannabis users, the risk is 9%. But those who have used in the past year, it's up to 36%. If someone uses cannabis daily, the risk for ultimately developing addiction is 25 to 50%. And importantly, this is sort of an indolent, insidious process that comes on. I think many individuals and their friends, family aren't even quite aware that the person has an addiction. So a very small percent, 5% actually seek treatment. On the psychiatric side, there can be development of schizophrenia, other psychoses, worsening of anxiety, depression, suicide has been associated with cannabis use, and also worsening of bipolar symptoms. I think for us as people treating those with MS, we often tend to think more in the neurological box, but I think addiction, psychosis, suicide, those are of concern. I think your radar really needs to be out for those. Other side effects, so there's some data for non-seminal with testicular cancer, increasing risk for that, and then emerging evidence for P16 positive oropharyngeal cancer, that's HPV associated oropharyngeal cancer. On the cardiac side, triggering of MI, orthostatic hypotension, dysrhythmias, driving operating machinery. There's about a twofold increased risk of motor vehicle accidents. On the GI side, cannabis hyperemesis syndrome, so uncontrolled nausea and vomiting, and there have been some recent case reports describing death due to that syndrome. Also decreased gut motility. And then with CBD, and this is in the cannabidiol PI, that there's potential for hepatotoxicity. So for the pharmaceutical grade CBD, LFTs are required before starting, 1, 3, and 6 months after starting, periodically thereafter, and then if there's increased dose or a drug is started that has potential hepatotoxicity, to check LFTs 1 month after that medication change. Potential risk for infection, so the CBD PI, so there's a 41% infection risk versus 30% in the placebo. The mechanism for that is not known, but those are the numbers that we have for women: lower birth weight, increased pregnancy complication, increased risk of infant admission to the ICU. And then for men, lower sperm count and lower sperm concentration. And then for lung cancer, that's still described as a risk for cannabis smoking, but there's really actually moderate evidence of no association, also no clear risk for genitourinary, biliary, renal, or thyroid issues. In terms of intoxication, it really isn't clear that there's been any human case of death due to intoxication with cannabis. But importantly, I've already described some side effects of cannabis that can lead to death, and that has been described. So stroke with RCDS in the setting of cannabis, also heart attack, suicide, psychosis, the testicular cancer I mentioned, motor vehicle accidents, the hyperemesis syndrome. And then especially in children with edibles, severe respiratory depression has been described. In terms of sort of special populations to be aware of, so pregnancy and breastfeeding. Cannabis is actually the most widely used illicit drug, but the American College of Obstetricians and Gynecologists made an official statement 5 years ago to discourage physicians from suggesting use during preconception, pregnancy, and lactation. And actually the Canadian PI for nabiximols, I've kind of quoted it here, men and women should use reliable contraception during treatment with nabiximols and for 3 months after discontinuation. So if you think of these side effects and then comorbidities that we see in our patients, MS-specific comorbidities to be maybe have a radar out for more, anxiety, depression, suicidality, seizures, constipation. And I already described how cannabis could potentially worsen those. Other comorbidities to be aware of are addiction, psychosis, stroke, coronary artery disease, others that I have listed there. In terms of real-world side effects, this is emergency room visits at University of Colorado, nearly 10,000 visits over between 2012 and 2016. In 2006, during that time period, that's when recreational marijuana became available, and the ER visits increased to about 10 out of 250 visits daily are cannabis related. Most frequent diagnosis are gastrointestinal symptoms, especially that hyperemesis syndrome. Interestingly, the GI syndrome is more common with the inhaled form. More common with edible is intoxication or psychosis or other acute psychiatric symptom and cardiovascular symptoms. So this is just my hypothesizing. There's a challenge in this area that we don't have any REMS program. There's no formal monitoring process that I'm aware of in any state that really diligently collects all the data on potential side effects. But like I say, addiction, that's quite common. And I think it's very much underdiagnosed cognitive dysfunction, especially in our MS population, potential worsening of anxiety, depression, balance falls. You can see the other concerns there. In my practice, just being in a state that's had cannabis legal in some form for many years, I've definitely seen many cases of addiction, cognitive dysfunction, worsening of anxiety and depression. I've seen a patient with RCVS who I kept giving more and more steroids to, and she kept getting worse, and it turned out she actually had RCVS and not an MS attack. Hepatotoxicity, I've seen that in multiple patients where the LFTs went up and it's thought to be due to the disease-modifying therapy, but it was actually because the person had started CBD, and then potentially seizure in someone who thought they were taking CBD, but may have been THC. So drug interactions, this is a complex area. The bottom line is we really do not have strong data in this area. Certainly don't have high quality human data. And as I mentioned earlier, herbs are very complex with a lot of unknown constituents. I think a great example is St. John's wort, where in the late 90s, it was thought, you looked at the authoritative text on herbs at that time, the German Commission e-monograph stated very clearly there were no drug interactions. There are now hundreds of well-described drug interactions with St. John's wort. So this is a quick summary, but in general, cannabis can interact with sedating medications, alcohol, sympathomimetics, anticholinergics. There's 2C9 inhibition, which can increase levels of some drugs that we use, can increase levels of warfarin, P-glycoprotein-mediated drug transport inhibition that can affect steroid, antidepressants, sedatives. Something quite important for us, I think, in the MS world is CBD, affecting ENT1, that's a nucleoside transporter, also BCRP and potentially the P450 isozymes that I have listed there. And then anti-epileptic drug levels can potentially go up or down. In the end, there are more than 100 possible drug interactions, and we just need more high-quality human studies to really be able to sort this out. This is just, think of this kind of like a heat map where it's, you can see the rows. There's THC, CBD, CBN, that's cannabinol, with drug transporters, cytochrome P450 and the UGT metabolizing system. And basically, the more dark boxes you see, the more concern there is for drug interactions. And you can see most black boxes are actually with CBD as opposed to THC or CBN. The cannabidiol PI has a lot of information about potential drug interactions, 3A4, 2C9. You can kind of go down the list there. It's very clear, and being mindful of these potential drug interactions. And then I think it's interesting to look at our disease-modifying therapies. So CBD, like I mentioned, there's potential for hepatotoxicity. We also have potential hepatotoxicity with multiple disease-modifying therapies that I've listed there. Like I said, cannabis generally has been associated with dysrhythmias. That can raise concern about S1P, disease-modifying therapies. It's potential for decreased effectiveness and increased toxicity due to increased blood levels with cladribine, maybe mainly through that ENT1. That, like I said, it's a nucleoside transporter, and cladribine is a nucleoside-based drug. And then also potential for increased toxicity with cannabis generally for teriflunomide and CBD specifically for siponimod through the interactions that I have listed. Then the final area I want to cover is these special considerations. I think this is territory that is just definitely not a bucket that conventional clinicians can put this into, because this is really territory that's novel to cannabis dispensary products. So contaminant storing stability issues, labeling, and dispensary staff. So in terms of contaminants, solvents are often used to extract the lipid-soluble cannabinoids. Some studies show up to 70% of products have residual solvent. Pesticides are used in the products, and up to 85% have been found to have pesticides. The cannabis plant absorbs metals avidly from the soil, so potential for heavy metals. There are various adulterants that can be found to increase the effectiveness, such as those that I have listed there. Also potentially harmful compounds in smoke when that's used. And then also recent studies indicating concern with the vapor in people who are vaporizing products. So that E-Valley, E-vaping associated lung injury appears to be associated with vitamin E acetate. That's not entirely clear. But then in addition to that, there's at least 7 groups of potentially toxic compounds in vaping products. And then microbes and fungal toxins, same thing. I think this is not something we think of in terms of drugs that we typically prescribe, because they're not herb-based. But like I said, in terms of infection risk, CBD itself might increase infection risk. I gave that data earlier. And then cannabis is potentially a TB risk factor. We have TB concerns with some of our MS disease-modifying therapies. And then the microbiome of the plant actually has gram-negative rods and fungi. Some of these may be pathogenic, and especially in those who are immunosuppressed. So aspergillus, and there are cases of not cannabis-associated aspergillus, but aspergillus generally with alemtuzumab and natalizumab, and then cryptococcus, especially with fingolimod. And then some of these fungi produce toxins. They can be toxic to the central nervous system, for example, with paxilline, or the kidneys with citrinin. And then you can just see here the microbiome analysis shows microbes of higher concern that I've already reviewed, but then there are other microbes that have been identified that are potentially pathogenic, and you can see the listing there. And I think something we often take for granted in pharmaceutical products is that they've been tested for storage and stability, and it says the expiration date and how to store the drug. That's not the case for cannabis products. So cannabis products are, the general recommendation is to store them in refrigerator or freezer conditions in the absence of light, and that's because the cannabinoids can decay into other cannabinoids. So you can have a product with a particular composition of cannabinoids, and if it's left at room temperature in light, those the constituents can change significantly. I showed you this earlier in the final segment there in the dispensary. I visit dispensaries regularly to know, actually I'm not a user, but to know actually what happens, and this is how things look in most dispensaries that I visit, where products are at room temperature and displayed under light. And then finally, I want to talk about the accuracy of labeling. There are many studies where there's been independent analysis of the labeling. One study that's often quoted was reported in JAMA in 2015, 75 products from San Francisco, LA, and Seattle. 83% of them were inaccurately labeled. There was negligible to 55% greater than what was on the label. So little to no cannabinoid, or 50% greater than what was on the label. The conclusion of this study was the labels failed to meet the basic label accuracy standards for pharmaceuticals. And then this is an interesting study. It wasn't presented in person at the AEN, but it's an abstract from the meeting where they looked at pediatric epilepsy patients, small group, 31. Some had Lennox-Gastaut and Dravet. Then they looked at, these were people using pharmaceutical grade CBD or dispensary, and you can see it's 22 for pharmaceutical, 9 for dispensary. And the blood levels, you can see much lower in the dispensary group. And interestingly, the seizure frequency went down in the pharmaceutical group, like we'd expect based on the clinical trials, but seizure frequency actually went up in the dispensary product group. Another area to think about is the staff, people who work at dispensaries. Most states do not require training for the staff. And you can see this large survey of 55 medical and non-medical staff in 9 states. 94% gave advice on specific product, but 80% of them had no medical or scientific training. 78% of them recommended products without known effectiveness or some that could worsen conditions. 21% recommended product just to move them out of inventory so they could clear the shelves for other products. This is a study done in my state where the dispensary staff were questioned through a phone call by a woman who said she was 8 weeks pregnant, had morning sickness. 69% of staff recommended cannabis products. 36% said that cannabis was safe during pregnancy, and only 32% recommended discussing this whole issue with a healthcare provider. In the Colorado, big survey of the Colorado cannabis industry, it was found that cannabis was used in 33% of staff while they're driving to work, 18% while they're at work, and 27% driving home from work. So how to translate this into practice? And you do have to be cautious in this area. The more specific you get, the more potential accountability, liability that you have. But the basic recommendations are to start low and slow. So the MS clinical trials, you know, much of this is with Sativex where you can do multiple sprays in a day, but twice daily up to 48 times per day. The starting doses you can see there, 5 to 15 milligram for THC, 2.5 milligram for CBD. And then the final doses, the THC on average was 20 to 40 milligrams per day, the CBD 10 milligram, but the maximum 120 milligram. Importantly, we don't have any pure, or we don't have a high CBD to THC study to quote in terms of recommendations. There are typical titration times for this starting low, going up slow, were 3 to 5 weeks. Importantly, as I mentioned, CBD has anticonvulsant effects. So as with all anticonvulsants, you don't want to abruptly stop it. So should be a taper there. Also important to keep in mind if someone's using mainly, if someone's using products that mainly have THC, if they're addicted, it could be very difficult to, might have to be a simple concept to try to get them off, but the practicality might be difficult. And like I say, it's, you have to have caution, you need to be cautious about getting too specific because that can then increase your accountability. So a lot of this depends on what state you live in. So this is a industry-sponsored site. I do think the information is quite reliable, but you can see that's sort of a diagram of the US. And this is cannabinoidclinical.com. And then there's something called the FDA difference. You can go to the map, you can click your state, and then it indicates what kind of testing is done, specifically for pesticides, heavy metals, solvents. This is the only place I know that even has this type of information put together. So in the end, I think we as clinicians just need to do what we know how to do, which is be objective. And for some reason, this area seems challenging for outstanding clinicians to be objective in. And I think it's some mix of not having the fund of knowledge and having those educational barriers. So we all know the equation here, benefit versus side effects, drug interactions. The extra element with cannabis is what I ended the talk with, labeling, storage, contaminants, dispensary staff. So I think the challenge is, can you fill the void? Can you get yourself educated, and then get your mind in a place to share that information in an objective way that's going to facilitate informed decision-making in patients you have who are using cannabis or they're thinking about using cannabis. So this is State Medical Board Federation that kind of came up with a step-by-step approach. And like I say, this is, we all know this, but for some reason, I don't think this is done 95% or more of the time when the topic of cannabis comes up. You need a collaborative clinician-patient effort. You have to document evaluation clinical history. You have to go through benefit, risks, unknowns, the special considerations. You need to have a written treatment plan. You need to monitor, adapt along the way. If someone's got addiction or mental health issues, you need to be mindful of that, and that could have a connection with cannabis. You have to have maintain records. You have to be with people in real time, kind of tracking all of this, and you certainly don't want to be selling products or other conflicts of interest that might interfere with your objectivity. So in summary, cannabis has been around for a very long time. The efficacy, safety, we're still working on. The pharmacology is quite complex and still being worked on. And then but even with those limitations, I think we can come up with a database of information that we should have as clinicians that we can share with our patients. So I'm going to give you some references here, and if you're not educated on this and you are interacting with people who use cannabis and you want to have productive interactions, I would highly recommend doing something about that. So this is free information on my website. This is what I use in clinical practice. It's Cannabis Information Sheet. It's got outline of the PI, so it's very familiar to clinicians and I think to patients. It's 1.5 pages, basically a summary of this talk. You can find this very quickly by just Googling my name, Bowling, and then MJ2. Also, I think it's very helpful for clinicians, but also I think for people who are using cannabis products, including sort of CBD that they might be buying from the just over the counter from a drugstore or a grocery store. So this PI for cannabidiol, I think that can be eye-opening for, like I say, clinicians and users. So you can just Google CBD PI and you'll get the document. It's 20 or 30 pages, like we typically see with PI. And then there are references. I think another excellent introduction, but covers lots of territories, that National Academy of Sciences. You can get to that by just Googling NAS Cannabis conclusion. And then a new book coming out in a few months. I wrote the chapter on cannabis, or in cannabis and MS, but it's objective evidence-based information with 30 or 40 authors in all different medical specialty and surgical specialty areas. So to me, this is kind of a quick introduction. You could Google these right now and get started. So the CBD PI, the National Academy of Sciences, and then that Cannabis Information Sheet. The Cannabis Information Sheet also has other references listed there. And then lots of other PIs for all the nabiximols. And then this talk is a summary of hundreds of articles on the topic. And then have acknowledgements here as well. So I'd like to end by just saying that, as I said earlier, a variant, like just be objective. If you're a clinician and you're talking to people about cannabis, I think it's your duty to, like any topic, to have objective database of information that you can share and curate for the person who's sitting in front of you. If you don't have that knowledge base, you need to develop it or just not get into the conversations. And then when you get into the conversations with a knowledge base, you really need to make sure that your head is in an objective place and you don't have emotions or politics interfering with that. So I'll conclude with that. Thanks for your attention, and I very much hope to see people in person next year at the annual CMSC meeting. Thanks.